Thank you. I want to expand a little bit on the comments of my colleagues. And I want to thank Dr. Byrne for constantly pointing out the business model, because I think the sustainability is critical. So if we think about the data sharing infrastructures, there's technical, which may ultimately be the easiest one to overcome, the governance, which we all struggle with, and of course the business model, how do we pay for it, and the sustainability. I believe that retrospectively adding data, which is what a lot of the efforts that GSK is doing and a lot of the other efforts that are ongoing, have a lot of issues that they're overcoming. The consent issue we've talked about, and the standardization. How can we make it, you can't really impose standardization retrospectively. And so that's going to impact the quality of the data and the analyses that then emanate when we add these trials together. The governance is always a problem, whether it is a industry or a government structure, NIH, or these national, even the international trials, and then navigating the complexity of the diverse institutions and government structures. And while I hate to add even more complexity onto what has been a day full of problems, issues, and barriers, a couple of institutions that I haven't really heard mentioned within the greater context of these conversations and in some of the IOM reports that have emanated from these discussions is the Department of Defense and the Veterans Administration. While we obviously do a lot of research with NIH as well as industry, there are a lot of databases and a lot of research that is funded by the Department of Defense and the Veterans Administration. And the ability of actually two government organizations to cooperate and trying to navigate the hurdles between two government agencies can be very overwhelming, and I can say this from personal experience. And if we think about it, our active service members have Department of Defense electronic health records, and the Department of Defense then provides us ultimately with our veterans. And the veterans then have DOD and VA medical records. And as a clinician in the VA, I can't even access the Department of Defense medical records to treat my patients if they're in my clinic. So if we can't navigate this hurdle, you can imagine the complexities of clinical trials and data sharing, even though these two government agencies working together makes all the sense in the world. There are a lot of new funding models actually between the DoD and the VA where they want shared funding of trials. And two of these that are recently funded are Strong Star CAP, which is the continued consortium to alleviate PTSD. And then also there is the CENC, which is the Chronic Effects of Neurotrauma Consortium, which are partially DoD funded as well as VA. And just navigating the hurdles between the different rules of these two institutions has been interesting, to say the least. The long-term outcomes of battlefield care could be greatly enhanced by linking the DoD and the VA medical records and looking at the VA patient populations and possibly even making the VAs as centers where patients can come in to find out the long-term outcomes data. A lot of the battlefield care that occurs recently with Operation Enduring Freedom, Iraqi Freedom, and New Dawn, really they have these DoD trauma registries that have about 48 hours worth of data. And then the veteran or the active service member leaves. And how do we link these trauma registries to the DoD records as well as to the VA records? Currently, the way we're doing this is predominantly with memorandums of understanding. And this then becomes limited to the data that has already been collected, and the consent issues for then working out how we would share the data once we had it, accessed it, and worked with it have yet to be navigated. So prospectively adding data, I think that there are a lot of wins that we can get from this, and the whole national efforts and international efforts on clinical trials networks will greatly help in this task. There are great advantages in patient accrual, which being, of course, one of the most common issues why clinical trials don't don't end successfully. And rare diseases such as children's oncology group studies and other types of diseases have really forced investigators to band together, which means you have shared protocols and oftentimes central data coordinating centers. And then to basically become part of the study, you could obtain buy-in as a condition of the trial that open access of the data would be a natural follow-on to the study after being able to analyze the data. We've spent a lot of time talking about clinical trials data, but there's also lots of other types of trials, such as epidemiologic studies, outcomes, and clinical data. And that leads into yet another government agency that is funding a lot of medical research, which is the Patient-Centered Outcomes Research Institute, or PCORI. And one of their most recently funded initiatives were the clinical data research networks. And this is 11 projects that are funded that look at electronic health records. Our institution is part of the Greater Plains Collaborative, which is 10 medical centers in 7 states that link 3 different diseases through the electronic health records. Most of the institutions that are involved in this really evolved from our relationships with our Clinical Translational Science Award institutions. And it's using the commercial electronic health records, in our case, Epic and Centricity for our network, and basically the patient portals to be able to pull data to have patient-centered questions and patient-centered clinical outcome trials. And there may be thoughts of eventually linking all of these 11 CDRN projects so that we could have more of a national network. So what are some of the challenges? Well, from an academic health center perspective, I think we lack expertise. And Ida Sims and I were talking about this in the break, that even if we wanted to recruit more bioinformaticians, data center coordinating, people with expertise in data center coordinating, these people just don't exist. And it's hard to bring them on board and training. And so when we have our bioinformaticians in our medical centers or in our medical schools, how much time do they spend in training the next generation of researchers that will take the charge, and how much time do they spend actually performing the work of coordinating the data and analyzing and coming up with new protocols for analyzing the data? And then the new data structures that are evolving through all of the different ways that we want to recombine data. I think the idea of centralization of clinical research procedures, which happens as an outgrowth of clinical trial networks, as well as cost-saving structures within universities, will be helpful in trying to have open access to data. We now do a lot of our research, at least in San Antonio, through our clinical research units. We also have compliance and for billing and a lot of structures that are centralized, which helps in at least getting our hands around the data. But unfortunately, adding the ability to have open access to the data adds additional functions, and these are largely unfunded. And then how will we evolve these research and data structures to be iterative, compliant, and actually being able to take advantage of the leaps in technology that we're now seeing? And how do we incorporate research into our learning healthcare systems? The trends in research, and there's a lot of conversation on not so much the randomized controlled trial, which is still, of course, the gold standard, but more on pragmatic trials, learning healthcare systems where we aren't taking a 3 or 4 or 5 year trial to then inform our care, but to have a constant learning environment. And how will we use open data access and sharing to help in this learning healthcare system? And I look forward to a very robust conversation.
Thank you, everyone. So a lot of gnarly questions on the table here. So I'll open up questions from committee members. Artie, looks like you're ready to go.